Hello and welcome to Healthy Living, brought to you by St. Tammany Health System. I'm your host, Melissa Hodgson, and we're talking today about cardiology, heart disease prevention and diagnosis, and the treatment that you can expect here in Covington. We have three cardiologists who'll join us today, Drs. Russell Reed, Paul Stahls, and George Antoun. So we'll start first with Dr. Russell Reed. Welcome to our show. We're glad to have you here.
I'm glad to be here.
So, Dr. Reed, I guess maybe start off with a little bit about your background.
Well, I'm a native from Mississippi. I was originally born in Natchez, and I did my college at Mississippi State, majored in microbiology, and actually got an MBA there as well. Then from there, did my medical training at the University of Mississippi Medical Center in Jackson. I did a residency in internal medicine, and from there went on to general cardiology and trained in interventional cardiology.
Outstanding. And your background actually kind of takes the same arc that many patients do. You started off in internal medicine and moved into the specialized area of cardiology. And I think if we can think about that for a minute from the patient perspective, if we've got good primary care, that may be the first place that we hear about heart disease.
Well, it is, and they're the primary care is important. They are the first line of everybody's care, because they're the ones who know the patients, and sometimes they start with triaging their risk factors and getting their labs and just talking to the patient, and they know the patients, and from there, whether patients come in reporting any symptoms or just in general an annual follow-up asking basic questions about cardiovascular health, if it's something that gets their attention, usually that's what triggers, okay, well maybe this is something we need to explore more and have them refer them to us. I mean, we really depend on them. They're our referral base, but also they take a lot of good care of the patients. It makes sense. Some things that we don't care for, diabetes management and these things. I mean, it starts in primary care, but whenever there's a question or concern, generally there's a pretty low threshold for them to come to us, and that's what we need and what we appreciate.
Well, and I think that's a good point. If I am going to see my primary care provider and I'm routinely doing that annual wellness visit that we have a tendency to just check that box because our health plan demands it or what have you, but truth be told, that annual visit is really where a lot of this kind of care can be escalated. So the primary care physician hears something from their patient and says, you know what, I think we need to have you talk with a cardiologist. And that's a little bit of a transition that takes the patient to a whole new place. So let's say my primary care physician has decided that I need to come see you. Tell me what that initial visit's going to be like.
Well, a lot of it is just going off of what's already been talked about from the primary care. It may be a very mild symptom, and it's our job to tease that out and get into the details of, okay, exactly what's going on. A lot of times by the time they get to us, they already have some lab work, and we always discuss that, discussing risk factors and lab work, and looking at cholesterol and blood sugars and those things to see what they look like, to see how that fits, really getting into their risk factors. And that's where it starts in primary care. We really try to break down those risk factors, say, okay, it's a lot of talking and teasing out, okay, what is your risk of whatever this symptom is actually being a cardiac issue? And so it's a matter of getting down to the symptoms and details, but also looking at the risks, looking at those risk factors and putting those two together. So, okay, do we have a real cardiac issue here that we need to get into, or is this something, okay, well maybe this isn't as serious as you should be, but that's where we really have to have an honest discussion and really get down to brass tacks about what's risk factors and what's going on.
Well, let's break that down. First, symptoms and then risk factors. So what are some signs and symptoms that people should be aware of?
Well, they're the textbook symptoms that you can look at, whereas we always ask basic questions of, okay, chest pain, shortness of breath, do you feel any palpitations? Those are very broad, but sometimes it's a lot more nuanced than that. I always ask about chest pain, but pain can be anything. It's very subjective. It's whether it's chest pressure, tightness, pulling. I mean, it can be a whole list of things. You know, I always tell patients, there's no wrong answer. Whatever you feel, you feel. That's my job to try to sort it out. And because it's not always the same, especially in women. The symptoms aren't always the same. Sometimes it's just as vague as, I don't feel like I should, or I was doing some work around the house or doing some yard work and just didn't feel like I could go like I used to. And that's where it's on us to have a low level of suspicion. So, okay, well, there could be something here that's, people are stubborn, and sometimes they don't admit when they're feeling bad. And so that's where we have to be a little more aggressive and make sure that we're getting the right information and then doing the right tests. And onto the question about risk factors,
right.
That's where that comes in too, because knowing people's risk factors, and patients need to know and what their risks are. High blood pressure, diabetes, if they're a smoker, of course here obesity is a big problem, or just general sedentary state. Those are all things that play a role. Of course, family history you can't do anything about, but it's important. We always have to ask about that. And so when you put symptoms and risk factors together, that will determine what we need to do, how aggressive we need to be. And of course, when you come into our office, we're looking at your blood pressure. We're going to go over labs. You'll have an EKG, so we can look at that. And then depending on how the visit goes and what you say, we'll determine what other kind of tests we need to do.
Okay. So basically, if you take all of those signs and symptoms, you take those risk factors, you have that conversation with the patient, then you're going to do some testing.
Right.
So can you describe a little bit about what kind of testing people can expect from the cardiologist?
Well, it can vary. There's a wide range depending on how aggressive we need to be. Sometimes it's as simple as, look, all you have is the EKG and you go about your way and we'll check on you in a year. Or sometimes we get in there and red flags start going off and say, look, we just need to go and do an angiogram straight off the bat because I'm worried about, with your risk factors and your symptoms, I think there's something bad going on. But generally, sometime in the middle, it's not uncommon where, hey, let's just start with a stress test, maybe an echocardiogram, which is an ultrasound where we can actually look at your heart structure and function and valves and make sure that's in good working order. Of course, always good to get people on the treadmill with a stress test to see what their exercise capacity is and to see if that tells us anything. And then we move from there. A lot of it is medication adjustments, all in the name of making sure that your symptoms are taken care of. We're not missing any bad cardiovascular disease, and of course having a good lifestyle, being able to function like a real person.
Absolutely, we all need to function like a real person. That's why we need good heart care. Okay, so you're going to take those signs and symptoms, those risk factors, you're going to maybe do some testing, things like an EKG or treadmill stress test, right? Up through maybe an angiogram. And that's going to tell you what that patient needs next. And it may be intervention, or it may be medication, or it may be some combination. But it's almost certainly going to involve some diet and exercise and some good healthy choices.
Well, always.
Very good. Well, I appreciate all of this information. I think you've helped us understand what we should be watching for in terms of our own heart health and how we can find our way into cardiology through primary care. Thank you, Dr. Reed. It's been a pleasure to have you on the show.
Thank you for having me.
You're watching Healthy Living, brought to you by St. Tammany Health System. We're talking about heart health today and learning about the specialty of cardiology. We'll be right back.
The North Shore has always marched to the beat of its own drum, and the cardiology team at St. Tammany Health System has always stayed in rhythm with the community we love so much. Here, many talented specialists and subspecialists devote themselves to providing minimally invasive cardiac surgery and the latest advancements in cardiac disease prevention. Together with our partner Ochsner Health, we're making St. Tammany hearts beat stronger.
Welcome back to Healthy Living, brought to you by St. Tammany Health System. I'm your host, Melissa Hodgson, and we're talking today about cardiology. We visited first with Dr. Reed, and he taught us a bit about primary care and initial workups in cardiology. Next, we'll talk about some interventional options with Dr. Paul Stahls. Dr. Stahls, welcome to the show.
Thank you for having me.
Really glad to have you here talking about heart health and heart disease. Let's start maybe with just your background. Tell us about how you came to be in cardiology.
I think that's best answered by my youth as a athlete, and I recall being on the clinical rounds in med school and just being absolutely drawn to cardiology. Undeniably, I couldn't find myself interested as much in any other field, because I remember what got me up off the field and off the mat all those years of playing sports, and it was the heart, and it was the incredible strength of the pump and of a normal functioning pump to keep me rolling and doing things. And if you look around, that's really the incredible story of human existence, is that there's a single normal heartbeat, considering the embryology and the formation of the heart, and it's just amazing to me.
And I agree with that. I think when you realize that every human being, there is a normal heart rhythm to a normal human being, and we're going to try to keep people healthy and recognize what that range is, I think it's fascinating. And you learn about that in your training, and you start off, as you said, in medical school, and then you choose a specialty and you go into cardiology, and you further specialized into something called electrophysiology. So can you talk a little bit about what that is?
Electrophysiology is a field that didn't exist when you and I were born, and it was a weird offshoot sub-room meeting at the American College of Cardiology for many years, and then a lot of guys, really smart guys and gals, researchers and folks that were interested in the electrical activity of the heart. And look, that interest began 150, 160 years ago, and the first EKG machine was about the size of this room, with a guy sitting with his foot in a bucket of salt water and getting one single heartbeat etched on a piece of smoked glass at a time, and identifying that there were detectable electrical signals that were derived from biochemical processes. Now, I don't want to get too technical, but that's, I suppose, part of the elegance and incredible nature of the heartbeat that I am referring to, is that every single heartbeat is a series of cellular activities. And there's a lot that we can do to continue to make normal rhythm and normal function, but there's a lot that can go wrong with that. And when it goes wrong, assessment of how those rhythms and arrhythmias are occurring and what they mean clinically is what I specialize in.
And you just used a word that we toss around in cardiology and heart care, arrhythmia. And even people who are faced with that learn to say that word. But if we break it down, what we're talking about is irregular rhythm. And so arrhythmia is part of what we're correcting, right? And so electrophysiology is one of the things that you can do, but there are lots of procedures that you can talk about that patients may benefit from if they have arrhythmia, or we say AFib, which is another short-term or shorthand that we use in the medical industry, and people learn to say, but they don't necessarily understand. So can you talk a little bit about some of those procedures?
Certainly. And I guess first, to talk about the arrhythmias themselves, there's a variety of them. A number of them arise from the top chambers. Some are because of extra wires that you're born with, and that's a very common phrase you'll come across, specifically with young, healthy people, called supraventricular tachycardia. That's commonly, 9 out of 10 times, going to be because of 1 or 2 extra wires that you were born with when you formed in your mama's belly. And those are, I don't want to say easy to fix, but those can be things that we absolutely fix, and fix once, and you should never have again. Then there's other arrhythmias that develop over time, and these kind of abnormalities can develop when you're a small child or a teenager, which are more rare and less common. And those, in fact, I put a pacemaker in a young lady who was 28 years old a couple of months ago because her heart would just stop. But now she's not passing out, and she really has a whole new lease on life. So there's a variety, and then within each of those varietous problems are a spectrum of abnormalities. And perhaps the most common is when we talk about the dysfunction of the middle-aged and older age patients. And we see a lot of dysfunction at different parts of the conduction system of the heart. And when we talk about them being wires or electricity, Understand, it's at the cellular level that we're thinking, and even sometimes the biochemical. So as it pertains to procedures, there's a variety. And if there's dysfunction of the conduction system where it pauses or doesn't work right, then we have pacemakers and defibrillators and devices that we can implant inside the heart that will maintain a heartbeat and not allow you to go for longer than we program that device to say, standardly 60 beats a minute. And so that's where pacemakers come into play, right? They're just wires that sit in the top and bottom chamber of the heart, sometimes with extra leads to provide different kinds of therapy. And those make sure you don't go too slow. Defibrillators are pacemakers that then can also treat bad rhythms that can kill you. And those typically arise when your heart has gotten sick from something else like cardiomyopathy. And that can be either from blockages or from infection or infiltrative disease. So defibrillator therapy, pacemaker therapy, that's a whole set of what we call device therapy. And the neat part there is those devices are shrinking. I've begun to put in a small device that's a pacemaker. It's about the size of a vitamin that you just implant in the right ventricle with no leads. And they're developing small pills, if you will, that are going to go in the top chamber of the heart and probably even off into the left ventricle. And we're going to be pacing folks with small little devices that don't even have wires. So we're in an evolution, and that's one of the most incredible parts of my field, is there is a constant technologic evolution as things shrink and become smaller in regards to the microprocessors, et cetera. Then when it comes to the arrhythmias that are fast, and atrial fibrillation being the most common one of which, there are the ablative processes that we can put people through. And what I do is go in through the veins, typically from the groin, because it heads back into the right side of the heart, and then from the inside of the heart with small catheters and small electrodes on those catheters, we can detect exactly where the arrhythmia is coming from, or spinning or arising, and then try to address it with ablative therapy.
Wow. So it's amazing to me that you're thinking about how electricity exists in our bodies and keeps us running, and everything that you do has to do with understanding whether those beats and those signals are too fast, too slow, pumping the blood where it needs to go, and that you are able to intervene in ways that are either non-invasive or minimally invasive to regulate the heartbeat and keep everything running smooth.
Yeah, and in our atrial fibrillation ablation, again, probably is the most common arrhythmia, and therefore demands the most ablative attention. Those therapies are evolving, and we're even evolving our understanding of exactly what's happening for them to arise. And so the interesting part is the neuroelectrophysiology, if you will allow a term, because of the innervation of the heart, where the neural ganglia and the innervation of the heart occurs, is going to be part of how we target therapy in the future. And what we can do is a stepwise progression of ablations to manage that. But unfortunately, despite that programmed approach and understanding of certain things that we're doing to block signals from entering the heart, sometimes we still don't conquer it or beat it, if you will, and that provides a lot of clinical challenge. We do have medicines that help us, and it can just be a very frustrating process. So that's when patients hear me talk about what we're going to do an ablation, they think, oh, great, check and done. Well, I envy my orthopedic friends, and they may give me a hard time for saying this, that you have a broken bone, they fix the bone is not broken. Well, that's not quite as simple as how we are working inside of the heart, because of the complexity of some of these arrhythmias and the level of disease. And Dr. Reed, I think, referred nicely to a lot of the risk factors. And I think if you think about what are the risk factors and what creates the substrate for this disease that we're referring to of arrhythmias, it is so inherently tied to basics of good diet, exercise, and weight loss. And I say that because I say that a lot to a lot of patients. Sleep apnea is a huge impact on the heart, and it's because of not allowing the heart to rest properly and large doses of adrenaline that cause, at the biochemical level, abnormalities. Beyond it, obesity, as much as we may culturally accept it here in Louisiana and Mississippi particularly, is absolutely a physiologic challenge. And so hypertension, obesity, sleep apnea, smoking, for gosh sake, I mean, the occasional cigar maybe, but 1, 2, 3 packs a day is just, it's got to be in modern parlance unacceptable. And we've got to move past that as a habit. In fact, we ought to make a pack of cigarettes $50 a pack, if you ask me. But those things are so impactful on the human body, and it sets up, it's really a matter of a battle of attrition in life. And the way I challenge my patients is to say, at 45, you need to be planning for 55, 65, and 75. And if you don't set the table, you're going to have a different version of that 55, 65, 75 than you anticipated. So you have to put in the time early, and you have to mind these kinds of risk factors and really stay on top of things. So having a very active lifestyle, keeping the weight down, eating a good diet. I say this, and we'll keep it direct. If you're seeing something advertised on TV to eat, you probably shouldn't eat it.
Okay. Excellent advice, Dr. Stahls. Thank you so much for coming in.
Yes, ma'am. Thanks for having me.
You're watching Healthy Living, brought to you by St. Tammany Health System. I'm your host, Melissa Hodgson. We're talking today about heart health and heart disease. We've met with Dr. Reed and Dr. Stahls, and up next, we'll meet Dr. Antoun. We'll be right back.
Everyone at St. Tammany Health System wants you to join our culture of people. People who care. People who make things just right. People who listen and appreciate you. People who celebrate your good days and understand the difficult ones. Join the health system where the people at your side make every day a fulfilling experience. Join the culture of St. Tammany Health System.
Welcome back to Healthy Living, brought to you by St. Tammany Health System. I'm your host, Melissa Hodgson, and we're talking today about cardiology. We're looking at heart disease, prevention, diagnosis, and treatment. We've talked with Dr. Reed and Dr. Stahls, and now we're talking with Dr. George Antoun. Welcome to the show.
Thank you.
Really glad to have you here. Maybe tell us a little bit about your background before we get started.
All right, so well, I was born and raised in Lebanon, in Beirut, the capital, and I went into high school and I graduated in 1999. And then I went into med school and did it for 6-7 years, and I graduated in 2006. I always dreamt to come to the United States, and I came to the United States to study medicine, and I got here in 2007, and I did internal medicine residency in East Tennessee State University. And for 3 years, graduated in 2010, and then after 2010, I decided to go into cardiology. I did extra 3 years in the same university, ETSU, and I graduated in 2013. And during that time, I decided to go into interventional cardiology. So I had the luck to go into interventional cardiology, and I went for 1 year to Detroit in Henry Ford Hospital and graduated in 2014. And after then, I came here to Louisiana, and I've been practicing ever since 2014. And here I am in St. Tammany.
Outstanding. And I think that it's interesting that interventional cardiology is the way that once things have gone wrong, we can really get in there and straighten some things out. But it's also where so much of the innovation in cardiology is coming in. I think, you know, we have talked about electrophysiology with Dr. Stahls, and I think there are lots of other types of intervention. So if you can maybe explain a little bit of some of the other types of intervention that you might describe or that you do for patients.
Absolutely. You know, it's very simple. The heart is a simple organ. It's a muscle that has structures. So if you look at it, it's a structure that beats every second. It gives you a heartbeat. So it's a pulsatile pump. So that pump, like any organ, it needs blood flow in order to function well, and that's the job of the coronary arteries. Coronary arteries are the pipes that bring blood flow to the heart muscle in order for that muscle to stay beating. So this is one of them. And then, as I mentioned, it's a structure. So this structure is a pulsatile structure that brings blood and makes the blood flow in only one direction throughout the human body. So in order for that blood flow to go through it in one direction, it has to have some valve structures. So really, other than electrophysiological procedures, so we have the coronary procedures and you have the structural procedures. So those are the three major procedure types in cardiology. So I deal with coronary interventions, so really basically dilating coronary arteries that are getting blocked, because blocked coronary arteries can lead to cardiovascular events, including death, stroke, heart attacks. I mean, you know, and the structural intervention, the most common one is a transcatheter aortic valve replacement nowadays, because it's been really booming. So those are the other procedures that we majorly, I mean, there are other procedures that are still there. I mean, they're more sophisticated, but you know, so that's it, the structural procedures and coronary procedures.
Structural and coronary. And you know, you just rolled transcatheter, transaortic, go ahead, say it.
The TAVR. So yeah, so other than coronary angioplasty, that nowadays there's a structural heart disease interventions. So in 2002, ever since that first transcatheter aortic valve replacement was done, innovation has happened significantly and progressed throughout the years. So historically speaking, aortic stenosis is a very common disease. In fact, after the age of 80, they say there's almost 10% of the population that has some sort of aortic stenosis. The aortic valve is the front door valve of the heart muscle. As I just mentioned, the heart is a pulsatile pump, so it has to fill and then to pump. To fill, you have the back door valve that opens, which is the mitral valve, the left ventricle, and then the front door valve is the aortic valve, and it has to pump through it. So narrowing of this valve can pose problems for the left ventricle, the main pump, and if this problem continues to progress, it gets to a point where the heart does not function well. So people can experience breathlessness, shortness of breath on exertion, sometimes congestive heart failure, symptoms like swelling in the legs, fluid in the lungs, and sometimes they can pass out from it, and sometimes they can die from it. So the idea is, because it's a disease that affects the elderly population, so a lot of people, when they get to that age, they are not candidate for open heart surgery, because classically open heart surgery is the way to fix those valves. But ever since 2002, after that first transcatheter aortic valve replacement that was done, I think in France, so the idea is you deliver a valve that is crimped on a balloon across the diseased valve, and you inflate the balloon, and you basically push that previous valve to the wall, and now your new valve is working. So basically you open that hole that is narrowed. And once you do that, they found that doing that, there's improvement in symptoms, less risk of death, and it's really, it's changed the whole pathology of severe aortic stenosis. And you know, once that procedure has improved, now in the past you used to do it only on very high risk patients, and now on high risk patients, now on moderate risk patients, and the valve's just getting better.
That's amazing. The valve is getting better, and your ability to insert that valve through minimally invasive procedures means that people who would have faced an open heart procedure are now just faced with that minimally invasive experience, and people who were not strong enough or whose risk factors were too high to have an open procedure are candidates for valve replacement because it won't be an open procedure.
Absolutely.
That's pretty fascinating. And I think Dr. Stahls was talking earlier about how fast technology is changing in cardiology, and I think TAVR is a very good example of that.
Absolutely, no question about that.
So I think we were talking about how the valve replacement works in minimally invasive, and that's TAVR. But there's also angioplasty, and that existed long before TAVR existed. And TAVR's technology is a little bit based on that, isn't it?
Absolutely. You know, it's basically opening a narrow space in the vasculature. So whether it's the aortic valve or the coronary arteries. So coronary arteries, I mean, again, heart disease is still the #1 killer. Heart attacks do happen, and they still do happen. Heart attacks happen when you have a blockage in the heart artery that decides to rupture and a clot forms, and then the blood, you have sudden cessation of blood flow to a part of the heart muscle. It all depends on how big is this heart muscle. That's what we call area at risk. If it's a large heart muscle that's at risk, you may die at home from a heart attack. So the idea of angioplasty is you go and where this vessel decides, you know, when you have a blockage, and that vessel, you open it up. We usually leave a stent nowadays. In the past, used to be just only balloon angioplasty when it first started in 1977. But nowadays, technology improved, and now you can leave a stent. So a blockage that was 70% becomes 0%. And you're basically preventing, if somebody comes with a heart attack, you fix the blockage, you know, you're making them live longer, you improve mortality and make them feel better. And the most important thing is the heart muscle itself. You save a lot of heart muscle, and saving heart muscle, that, you know, means improvement in quality of life and improvement in longevity. And so, yeah, angioplasty has also gone a long ways.
Wow. Well, Dr. Antoun, I really appreciate you coming in today to talk about these types of intervention. It's been really educational.
Thank you so much. Appreciate it.
You're watching Healthy Living, brought to you by St. Tammany Health System. We talked today about cardiology, and we hope that you'll join us for a future episode of Healthy Living.